Hi everyone. Welcome back. In this video, we have an extremely important and informative EKG quiz. So, let's go through the quiz. This tracing belongs to a 63-year-old man, known case of dyslipidemia, presented to emergency department with chest pain since 6 days ago. His physical examination was unremarkable. An EKG was obtained. What do you think about this tracing? What is your plan? As before, in order to interpret the EKG flawlessly, use the 10-step approach. Let's start with the first step, that is standard values and calibration. Here, the calibration marker is 2 large boxes tall, and 1 large box wide. On the other hand, the EKG speed and voltage are 10 mm per second, and 25 mm per millivolt respectively. Therefore, this is a standard strip. Second step is cardiac rhythm. As you know, there are 3 main steps in determining every heart rhythm. First, locate and examine P-wave morphology. Fortunately, the P-waves in this tracing are discernible. They are identical and upright in D1, D2, D3, V3 to V6, and negative in AVR. Therefore, the P-waves are originating from the sinus node. Second, locate and examine QRS complex morphology. Here, the QRS complexes are nearly 2 small boxes in duration. So, we have narrow QRS complexes. The complexes are uniform as well. Therefore, all ventricular beats have the same origin. Third, describe the relationship between the QRS complexes and P-waves, using P-QRS ratio and intervals, including RR interval, PP interval, and PR interval. The P-QRS ratio and intervals play a crucial role in establishing the true relation between QRS complexes and P-waves. Here, the P-waves are associated with QRS complexes in a 1-to-1 fashion. The PR intervals, PP intervals, and RR intervals are stable. There is no drop beat. So, the AV node is healthy and no AV block exists. Therefore, the rhythm is regular. In conclusion, the underlying heart rhythm is normal sinus rhythm. Third part is calculating heart rate. As we already explained, thanks to the regular rhythm, RR interval is stable. The RR interval is nearly 5 large boxes. Therefore, the heart rate is 60 beats per minute. Fourth step is axis analysis. Here, the QRS complexes are positive in D1 and D2. So, the axis is normal. Fifth section is examining the P-waves. As we said before, the P-waves are sinus. Both amplitude and duration of the P-waves are 2 small boxes. Therefore, no LA or RA abnormality is present. Sixth step is the PR interval. The PR interval is 4.5 small squares, which is within normal ranges. So, no AV nodal block, including first-degree AV block exists. Next part is QRS complexes. As usual, examine 4 items to establish the complex changes. 1. QRS duration. As we said in the second part, the QRS complexes are narrow. So, any form of conduction abnormality, including bundle branch block, WPW syndrome, hyperkalemia, or ventricular rhythm is absent. 2. QRS amplitude. As it is clear, the amplitude of all QRS complexes is less than 5 mm in limb leads, except D2. In lead D2, the amplitude is slightly higher than 5 mV. So, the complexes are considered as relatively low voltage in limb leads. On the other hand, none of the criteria of ventricular hypertrophy are present. In summary, the QRS complexes are low voltage. 3. R wave progression and transition zone. QRS complexes in all precordial leads are negative owing to QS pattern. No discernible R wave is present in precordial leads. So, the QRS complexes have negative concordance. 4. Examine pathologic Q waves. Here, are deep Q waves in all precordial leads. No discernible pathologic and non-pathologic Q is present in limb leads. In summary, pathologic changes of QRS complexes are negative concordance thanks to pathologic Q waves and low voltage complexes. Next part is examining STT changes. The most debating section of this tracing is the STT changes. There are prominent ST elevations, with concomitant biphasic D waves in precordial leads. Note that the terminal portion of D waves is deeply inverted. Therefore, we have deep terminal D wave inversion in precordial leads. There is a wide spectrum of differential diagnoses for deep or giant D wave inversion. The most important causes of giant D wave inversion are severe right or left ventricular hypertrophy and hypertrophic cardiomyopathies, acute ischemia like Welland syndrome, massive PTE, neglected MI, LV aneurysm, cerebral hemorrhage, acute abdomen including acute pancreatitis, and so on. Associated ECG findings and patient history play a critical role in detecting the underlying cause of giant T wave inversion. Let's go through the differential diagnoses step by step. In this electrocardiogram, neither RVH nor LVH criteria are present. Therefore, ventricular hypertrophy and hypertrophic cardiomyopathies are not probable. What about the Welland syndrome? As we all know, the hallmark of Welland syndrome is deeply inverted or biphasic D waves in precordial leads. So, someone might wonder that this EKG is demonstrating Welland syndrome. But that's not true. Remember that deeply inverted or biphasic D wave does not suffice to diagnose Welland syndrome for sure. In Welland syndrome, we do not expect to observe poor R wave progression or pathologic Q wave in precordial leads. But as you see, both pathologic Q wave and negative concordance are present in this electrocardiogram, which exclude Welland syndrome as the possible cause of T wave inversion in this case. Remember that troponin level may be normal in Welland syndrome. In massive PTE, we usually expect to discover sinus tachycardia, right axis deviation, S1Q3T3 pattern, right ventricular strain pattern, like new RBBB, or concomitant D wave inversion in precordial and inferior leads, and so on. While in this strip, almost all of these features are absent. Therefore, as far as the EKG is concerned, PTE is less likely. Note that patient's history is not compatible with cerebral hemorrhage or acute abdomen. Let's review our abnormal findings again. As you see, the most abnormal findings are pathologic Q waves with subsequent negative concordance, precordial ST elevations, and deep T wave inversions. This triad is highly compatible with neglected MI or LV aneurysm. LV aneurysm and recently neglected MI are electrocardiographically similar. So, we are not capable of distinguishing them by EKG. Remember that the time course of the acute infarction is very important to make neglected MI and LV aneurysm apart. The suspicion of an aneurysm is based on the duration of this pattern greater than 3 weeks after the acute myocardial infarction. Therefore, according to our patient's history and electrocardiographic findings, recently neglected MI is the most possible cause of chest pain. Note that low-voltage QRS complexes in limb leads is possibly thanks to the underlying ischemia and malfunctional myocardium. Again, we re-emphasize that the presence of pathologic Q waves with coexistent ST elevations and T wave inversion is highly suggestive for recently neglected MI or LV aneurysm. The ninth part is QT interval. Here, the QT interval is about 12 small boxes. So, the QT interval is about 480 millisecond. Since the heart rate is 60, the corrected QT interval is 480 millisecond, and therefore is slightly prolonged. Remember that ongoing ischemia like our case is one of the well-known causes of QT prolongation. The last step is overall interpretation. Before going through this part, if you liked this video till now, please subscribe me and ring the bell for further videos. To make a perfect interpretation, we are supposed to list the abnormal findings first. In this strip, the abnormal findings are negative concordance due to pathologic anterior Q waves, low voltage complexes in limb leads, widespread ST elevations, with coexistent giant D wave inversion in precordial leads, and slightly prolonged QT interval. As we already said, pathologic Q wave, with accompanying ST elevations, and T wave inversion, are very highly in favor of recently neglected MI. Long QT and low voltage QRS complexes are possibly thanks to ongoing ischemia as well. To put it in a nutshell, nearly all EKG abnormalities are as a result of ongoing ischemia. According to EKG findings and patient history, management of ACS, especially dual antiplatelet therapy, is our priority. Note that, since ischemia is lasting over 48 hours, treatment with fibrinolytics is no longer effective and must be avoided. Thanks for watching this video. If you liked this video, please subscribe me and ring the bell. Good luck.